Hi everyone, this is part 2 of the heart chapter. So last time we finished up by talking about blood flow through the heart, and so now we're going to talk about valves, their function and their structure and what causes them to open and close. And then we'll move on through the coronary circulation and the conduction system of the heart in this video. Okay, so first of all with valves, the function of a valve is to make sure that blood flows only in one direction. All right, so we don't want any backflow of blood. And that's going to be the function of the valves, is to prevent blood from backflowing. Okay, and so they're going to open and close in response to changes in pressure. Okay, and so our AV valves, so these are the valves between the atria and the ventricle. So that would be our tricuspid and our bicuspid valves. So the AV valves are going to open when the pressure in the atria is high. All right, so when we have a higher pressure in the atria than in the ventricles, those valves are going to open, allowing blood to move into the ventricles. And then that valve is going to close when pressure in the ventricles is higher. All right, so ventricle is high. So that means higher than in the atria, all right? Because this is a valve between the atrium and the ventricle, okay? So it's going to be pressures in either the atria or the ventricle that's going to determine if they open. Okay, and then we talked about in the last video briefly those chordae tendineae, or the heartstrings that kind of anchor the valves, those AV valves, in place. So these are essentially collagen threads that attach to those valves and prevent them from kind of inverting instead of just closing nicely. All right, so they're going to kind of hold those valves down, and they attach to papillary muscles. Okay, so these are going to attach to papillary muscles. Okay. And so then we also have the semilunar valves that we saw. So we saw the pulmonary semilunar valves and the aortic semilunar valves. All right. And so these semilunar valves are, again, they're going to be dense connective tissue, just like the AV valves are. And they're going to kind of flatten against the walls of those blood vessels when they open. All right. And then when they close, they're going to kind of pop open into that kind of semilunar cup shape to catch blood and prevent it from moving backwards. So they're going to open when pressure in the ventricle is high. All right. And then they're going to close when the pressure in whatever vessel we're talking about, whether it's the pulmonary trunk or the aorta, is high. All right. So they're going to close when pressure in that vessel is high, and that'll prevent blood from moving backwards back into that ventricle. All right, and so also pertaining to the valves is the heart sound. So if you ever use a stethoscope to listen to somebody's heart beating, what you are actually hearing, that kind of lub-dub sound, is the closing of the heart valves. Okay, and so that first sound, all right, that lub sound, so this is the first sound, is from those AV valves closing. All right, so you actually hear those valves like snapping shut. Okay, so the AV valves close, and then you hear that dub sound. That is the second sound, all right, it's referred to as the second heart sound, and that is those semilunar valves snapping shut. Okay, so what you're actually hearing with the stethoscope is the physical shutting of those valves. Okay, and so then you can also, with valves, have some problems, all right? And one of those would be a stenosis, okay? So a stenosis is a narrowing of a valve. And so narrowing of a valve typically would come from kind of accumulation or deposits of things like calcium crystals or scar tissue on the valve itself, causing that opening, that valve to narrow. All right, so this could be from calcium deposits, all right, or scar tissue, for example, following endocarditis we talked about. That could lead to a stenosis or a narrowing of that valve. Okay, so now let's go through the coronary circulation, okay? And so before we talk about some of the blood vessels and what tissues they supply, the function of the coronary circulation and why it's so critically important is to nourish that actual heart tissue, the heart muscle. All right, so it nourishes the heart muscle. So the heart's job is to get oxygenated blood from the lungs and send it to the body. So to send oxygenated blood to the body. But the heart, containing all this muscle that works very hard, nonstop all day, also needs nourishment itself, right? It needs oxygen, it needs glucose and all that stuff. So it is the job of that coronary circulation to bring that nourishment to the muscle tissue, okay? And so the coronary circulation branches off of the aorta. Okay, and so what we have are a right coronary artery which branches off. We can't really see it, so I'm going to kind of just add in where it would be. So it would kind of branch off of the aorta here, all right, and it would kind of loop around like this, all right, to those blood vessels we see there. Okay, so we have a right coronary artery branching off the right side of the heart, and then we have a left coronary artery, all right, branching off the left side of the heart, all right, like this. Okay, not the left side of the heart, the left side of the aorta, sorry. Okay, so that's our right coronary artery and our left coronary artery. Okay, so let's talk about some of the important branches off of the right coronary artery. All right, so off of the right coronary artery, we have the right marginal artery. And so this artery is going to send blood to the lateral and right side of the heart. All right. Okay, and so it's gonna be this blood vessel. I'll just kind of draw an arrow. All right, this branch here. And so typically that marginal artery will branch off of the right coronary artery and kind of move down towards the, along that lateral wall of the heart. All right, so it branches and it'll kind of travel in this layer of fat here along the lateral wall of the heart. Okay, and then also branching off of the right coronary artery, although we can't see it on this picture, is the posterior interventricular artery. Okay, and so this is going to supply blood to the posterior ventricles. So interventricular meaning it goes through kind of between where the ventricles are. Posterior ventricles. All right, so we can't see that on this picture. It would be on the posterior side of the heart. Okay, so now the important vessels branching off of the left coronary artery. So on the left side, we have major coronary artery called the anterior interventricular artery. Anterior interventricular artery. And so this is the major blood vessel that is going to send blood to the anterior, basically the anterior ventricles. All right. So anterior ventricles. And so this is the artery if, somebody has, if you've ever heard of like a widowmaker, all right, heart attack, that would be from a blockage in this blood vessel. And so it is going to be this one right here that travels down the front of the heart, all right? And it's going to actually travel in. There's an interventricular sulcus, kind of a groove between the two ventricles, and it kind of travels in this layer of fat that goes down in that sulcus. Okay? And then we have the circumflex artery, all right? So circumflex meaning it kind of wraps around the side of the heart like this, all right? So that circumflex artery would be kind of tucked up here underneath this auricle, right? That little flap on the outside of the heart. And that circumflex artery is going to send blood to the lateral atria and some of the posterior left ventricle. All right, so lateral atria and posterior left ventricle. Okay. All right, and then another one we can't see because it's on the posterior side of the heart is going to be the coronary sinus. And so the coronary sinus is a like large vein that carries deoxygenated blood back to the right atrium. All right, so it carries deoxygenated blood to the right atrium. All right, so then it can join the rest of that deoxygenated blood from the body and go receive oxygen from the lungs. Okay, so it's kind of the end of this journey of the coronary circulation. All that blood, after the oxygen has been used by the cardiac muscle tissue, will return to the heart via this coronary sinus. Okay, whoops. All right, so a couple implications and some terms you've probably heard of pertaining to coronary circulation. First of all, an anastomosis. All right, so you may not have heard of this, but this is a very, very important concept to understand. And so an anastomosis is a connection between blood vessels. All right, so, and you can have a few different kinds of anastomoses. You can have, connections between arteries and veins that are directly connected with no capillary bed in between. But in this case, with the coronary circulation, we are specifically talking about between arteries. All right, and this is important with coronary circulation because it provides kind of like backup blood flow to the heart. All right. So if you get a clot or some sort of blockage in like some sort of plaque or something, maybe in one of your coronary vessels, typically there are going to be these anastomoses, these other connections coming from other places that can kind of bypass that blockage and still send nourishment and oxygen to that area. All right, and so one important anastomosis is between the anterior and posterior interventricular arteries. All right, so they actually kind of around the apex of the heart here, right, they actually will connect with each other. Okay, and so if there's something that happens in one, the other can kind of help to send blood to that lacking tissue. All right, so that's an anastomosis. So it's kind of like a backup system with the coronary blood supply. However, if there is severe blockage to a blood vessel, it could mean that that cardiac muscle tissue doesn't get the oxygen it needs. And so that is called ischemia, right? So ischemia is a decrease in oxygen supply, all right, so to a specific tissue. So here we're talking about the heart, all right? So that could, if it's prolonged, lead to tissue death, all right? And so this frequently lack of oxygen can be very, very painful, all right? And so when it's happening in the heart, that's called angina pectoris, all right? So this is chest pain associated with a decrease in oxygen to the heart. All right, there we go, decrease oxygen to the heart. And so that causes like physical chest pains. That's called angina pectoris. So chest pains from a decreased oxygen to the heart. Okay, and so again, I said you can have muscle tissue death if that ischemia is prolonged, and that is called a myocardial infarction. So this would be cardiac muscle death. All right, so that could be from prolonged lack of oxygen to the tissue. Okay. All right, so that's the coronary circulation. So now we're going to transition and talk about the conduction system in the heart. All right. And so the first thing we need to talk about is the fact that the heart has these cells that are called pacemaker cells. And so they're very unique because these are cells that are self-excitable. All right, and so self-excitable means that they can generate their own action potentials. Okay, so they can make their own action potentials. All right, and so that's very unique. When we talked about muscle in, skeletal muscle in A&P1, you had to have a motor neuron from the nervous system to cause an action potential in that muscle cell. The heart's unique because it has these special cardiac muscle cells called pacemaker cells that can make their own action potentials. All right, this is only 1% of the myocardium that can actually do this. All right, but that's all you need because remember, cardiac muscle cells are connected to each other by those gap junctions. So once you get that action potential started, it will very quickly spread through the heart. All right, so that 1% will depolarize the rest of the heart. Okay, so let's talk about how specifically those pacemaker cells work. Okay, and so the first pacemaker cell we'll talk about will be the SA node. All right, because that's the primary one. Is the SA node. It's going to set that normal rhythm of the heart. All right, and so when you look at the electrical activity in a pacemaker cell, this is what it looks like. All right, and so what you have, we'll kind of start with the red here in the middle. All right, because that's our very slow depolarization. Okay, and so with this slow depolarization, we have slow sodium into the cell. All right, so slow sodium moving in. That's a lot like depolarization we've seen before. It's just happening a lot more slowly than we normally see. Okay, and so it's going to be a very slow movement of sodium into the cell. All right, we'll talk about kind of why that happens in a minute. And then that cell is going to reach threshold. All right, so this dotted line is threshold. Okay. And that threshold is going to cause a very fast, all right, calcium influx, right? So fast calcium in, that's going to be this green part, okay? And that's going to very quickly finish the depolarization of that cell, right? That action potential will peak. And then we'll have repolarization by potassium moving out, as we've seen before. Okay, so what's unique that allows these cells to make their own action potentials is that as we reach this point, which you guys learned in A&P1 is called hyperpolarization. All right, that hyperpolarization, that dip in the membrane potential below threshold, right, and below rest, is going to open, right? It opens slow sodium channels. Okay, so the fact that that cell hyperpolarizes causes those slow sodium channels to open, and then that immediately sends us to starting up this new action potential. So we slowly let sodium in, and then we'll reach threshold, send another action potential, and then that can keep going on over and over and over and over. because the hyperpolarization following the previous action potential initiates the next one by opening those slow sodium channels. Okay, so that's very unique about those pacemaker cells. All right, so they can just keep going and going and going, sending these kind of rhythmic action potentials. All right, and so with these action potentials coming from that SA node, all right, they have a set rhythm that's called the sinus rhythm. All right, it's set by, and we'll look at that SA node and where it is, but it's set by the SA node, okay? And that is 75 approximately beats per minute. That's that sinus rhythm, right? So beats per minute. Okay, so let's look at the actual conduction system of the heart and where these structures are located. Okay, so if we look at a picture of the heart like this, what you're going to see is, so these kind of green structures, that's going to be the conduction system of the heart. So the SA node we've been talking about, the sinoatrial node, is going to be located up here, right? So that's the sinoatrial node. And so it has those pacemaker cells, and they fire an action potential 75 actually action potentials every minute to set that sinus rhythm. All right, so they're going to send that information. It's going to spread through the atria, all right, and it's going to spread out here, and it'll actually cross over to this atria over here. All right, so it's going to send that action potential. Remember, these cells are all linked to each other by those intercalated discs, so it's going to spread that action potential throughout. And then it's going to reach this next structure called the AV node, the atrial ventricular node, all right, which kind of relates to its location. So it's kind of right between the atrium and the ventricle. So that's the AV node there. Okay, and so the AV node is slower than the SA node. So the AV node actually has its own pacemaker cells, and they fire at about 50 beats per minute. Okay, so it's slower, and so essentially it's overridden by the SA node, which is faster and sets that sinus rhythm, but it does have its own pacemaker cells. But the function of this AV node here is that it slows down that impulse. It delays it by just a fraction of a second. All right, so it delays impulse, that action potential, by 0.1 second. Okay, so it's just that very, very slight delay, but that is a very, very important delay because it allows the atria to finish contracting, right, before we start depolarizing our ventricles. All right, and so that's extremely important. All right, so it allows the atria to contract, and then the ventricles at the time the atria are contracting are going to be relaxing. All right, so the ventricles can also fully relax. Okay, so that little delay that comes from that AV node is very, very important functionally, even though it's just a fraction of a second. All right, a tenth of a second. Okay, and then from there, that impulse is going to be sent through this kind of structure here, right? It's kind of branch. It's called the bundle of His. All right. And so the bundle of His sits kind of in the superior part of that interventricular septum between the right and the left ventricles. And so that is going to carry that information because there is a connective tissue kind of block between the atria and the ventricles. And so this bundle of His carries that impulse through that connective tissue into the ventricles. So now it can spread through the ventricles. All right, and so it does that by then traveling through these right and left bundle branches. And then, hold on just a second. Okay. The right and left bundle branches, and then it's going to spread out into all of these smaller little filaments that are going to travel out through the ventricle wall. These are all going to be called Purkinje fibers. All right, so these are Purkinje fibers. And so that'll send that information throughout the ventricle, so then they can all contract in a synchronized way. Okay. All right, so before we look at an ECG, I just want to point out two terms really quick. All right, and I don't have them written here yet. So let's just add, all right, fibrillation. All right, and so you may have heard of fibrillation before. So fibrillation, which actually has two L's, I left one out. Oh my gosh. Okay, so fibrillation is just the lost synchronized contraction in the heart. All right, so fibrillation is uncoordinated, kind of more random contraction of the heart. All right, so uncoordinated contraction of the heart. And a little later, in this chapter, when we're kind of talking about kind of the function of the, contraction of the atria versus the ventricle, we'll talk about there can be atrial fibrillation and ventricular fibrillation, okay? And those can have different effects. But for now, we'll just introduce the term. And then the other term is going to be defibrillation. All right, and so you guys may have heard of a defibrillator, all right? And so that is used to kind of reset someone's rhythm, all right? So you essentially give them an electric shock to essentially kind of like wipe that slate clean and reset the rhythm so that SA node can kind of take over and help to re-coordinate the contraction, all right? So that defibrillation is going to reset that rhythm. Okay, so fibrillation and defibrillation. All right, so now let's talk about the ECG. So this will be the last topic for this video. All right, so ECG or electrocardiogram, also called an EKG, right? That's referring to the same thing, is when you place electrodes on the skin to detect electrical signals from the heart. All right, so this, the typical ECG is going to be a 12-lead ECG. That means there's going to be 12 different electrodes placed on different areas. All right, and they're going to kind of read electrical activity from different angles on the heart. All right, so it's an important concept to understand with the ECG that what you're seeing is a combination of all of the electrical activity in the heart at a given time, right? Not a specific single action potential. Okay, so that's why some of these little, bumps and waves and stuff are going to be a little more complex, because at one moment in time, you're seeing all of the electrical activity in the heart. Okay, and then one more thing, when you're looking at these ECGs, all right, we are going to look at lead 2. That's kind of the typical ECG trace that you'll see. When you see a positive wave, all right, so a wave that goes upward, all right, that's a positive wave. All that means is that the activity, right, the electrical activity is moving towards the lead, okay? And a negative wave means that activity is moving away from the lead. And so if you look at some of the other leads of the 12-lead ECG, there are ones that almost look like an inverted version of this, all right? And a lot of people are like, oh my gosh, what's wrong with that person? But it's just because that electrode is placed in a different location. So whereas we're seeing this positive wave here on a different location, it may look negative like this just because that electrical signal is moving away from the lead where it's placed. Okay? All right. So let's talk about the different components of this ECG. Okay, so we can first have our major different structures we'll label, and then we'll look at some kind of smaller regions that can be measured for different heart functions. All right, so the first structure is going to be this P wave. So this first bump here. Actually, let me move this line over a little bit so I have a little more room to write. All right, so the P wave is that first bump in an ECG, all right, and it represents atrial depolarization. All right, so the P wave represents atrial depolarization. All right, so make sure you understand that, right? I'm saying atrial depolarization, not atrial contraction, because here we are looking at electrical activity. And although when the atria depolarize, generally that heart is going to follow shortly after by contracting, we are only looking at electrical activity. So we can say that the P wave represents atrial depolarization. All right, that could be followed by atrial contraction. All right, but that's not what the P wave is, right? It's electrical activity. Okay, and so this would be this P wave, kind of what's happening here is the electrical information is going from that SA node. It's being sent out through those atria, right? They're depolarizing. And then we get to our next structure, which is here, all right? This is our QRS complex, okay? And that's because we call this point Q, this point R, and this point S, okay? So it's called the QRS complex. It's this big spike. And that QRS complex is ventricular depolarization. All right, and so those ventricles are huge, right? And so that electrical activity has a long way to travel and a complex journey to travel through those ventricles. And so that's why this is such a strange shape. And also because this is so large and the ventricles are so large, it's going to also mask the repolarization of those atria, right? So we don't see the repolarization of the atria just because it's masked by this QRS complex, okay? And so then our last kind of big structure on here is going to be this T wave right here, all right? So the T wave represents ventricular repolarization. Okay, and so those ventricles are going to repolarize, and that's going to happen during that T wave. All right, and so that generally that T wave is a little longer because repolarization takes a little longer than depolarization. So it's a little longer than the QRS complex. Okay, so a couple of additional features you can look at with an ECG. The first one is the PR interval, or sometimes it's referred to as the PQ interval. All right, so that would be located right here. Okay, so this would be All right, so PQ. So that PQ or PR interval is going to be the time it takes for the atria to depolarize, and then we include this little section here because it also is the time for them to contract. All right, so atria to depolarize and contract. All right, so that is the PR interval. Okay, and so this will be the time it takes for the information to go from the SA to the AV node and then be passed along, because the next thing that'll happen is the ventricles will depolarize. And so if there is a delay in this, right, if it's prolonged, this is one that it's really important to look at, because if it's prolonged, that could indicate damage to muscle tissue. All right, so, and I'll show you why in just a second. All right, so muscle tissue damage. And so that's because if we look back up here at this picture, all right, if we have our information traveling from this SA node to the AV node, all right, it should have a pretty straight shot, okay? And so generally it'll take about the same amount of time, about 0.16 seconds to get from here to here, okay? However, if there's some sort of like a myocardial infarction, muscle death in this area, all right, it is going to take a little longer, because now that action potential has to travel around that area through healthy tissue to reach that AV node. Okay, so if there's a delay in that time, that PQ interval, that could tell you something about the health of the tissue in that atrium, all right, and how well it's conducting that impulse. Okay, and so then our next kind of section, right, is the ST segment. Okay, and so the ST segment, I'll kind of put it on the bottom here, would go from here to, to here. All right, so this would be the ST segment. Okay, so the ST segment, what's important about it is generally you look to see, is it on baseline? Okay, so is it, if we drew kind of a straight line all the way across here, right, is it on baseline, right? Is it elevated or something like that? And so what that will tell you is if that myocardium is getting enough oxygenated blood, right? All right, is myocardium being oxygenated? All right, so that's an important feature to look at. And then we have the QT interval. Okay, and so the QT interval would go, I don't want to make like a huge mess with a bunch of crossing lines, but it would go from Q here to the end of T out here. All right, so that would be our QT interval. And so what we look at with the QT interval is it tells the time for the ventricles to depolarize and repolarize. All right, so depolarize and repolarize. And so that can tell you something about the conduction system in the ventricles themselves, and if maybe there's damaged tissues in those ventricles. All right, and then lastly, you can look at the amplitude, so how tall this R kind of peak is. Right, that amplitude can tell you something about the size of the ventricle. Right, so if it's very, very large, that could indicate an enlarged ventricle. All right, so an enlarged ventricle, just because of that amplitude of that R kind of peak. Okay. All right, so that is the ECG, all right, and so we're going to leave that here for this video, and so then in our last video for this chapter, we'll go through the cardiac cycle, all right, so that's how the atria contract, and then the ventricle contract, and that rhythm, and how they work together, and then how your body can alter that rhythm and increase that cardiac cycle and increase blood flow and that kind of thing. All right, so that'll be in our last